Welcome everyone to the August 18th, 2020 COVID-19 clinical rounds critical care session focused on life-saving treatment and clinical operations. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 critical care challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated, and welcome the Commission on Accreditation of Medical Transport Services as a collaborator for the rounds. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Thursday, August 13th, will be emergency department rounds focused on COVID-19 and wildfires. Stay tuned for announcements for future rounds. A special note, however, regarding future rounds. During the August 10th COVID-19 clinical rounds, 78% of respondents to a polling question indicated that their organization was fatigued. Fatigue, complacency, mental health, and deaths of clinicians remain major challenges discussed during these rounds. We'd like to do something that will lighten your load and take something off your calendars, and it will give our team a chance to catch our breaths as well. All COVID-19 clinical rounds, including the Monday EMS, Tuesday critical care, and Thursday emergency department rounds for the week of August 24th, next week, we'll be taking a week off. We will restart rounds on Monday, August 31st, as per usual, focused on EMS. We hope that you take the time that you may have participated in the rounds next week to do something that is supportive of your mental health and that reinvigorates you. We also hope this is a tangible symbol that puts a spotlight on the need for clinicians to take care of themselves. We will continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds we've had to date, we continue to have participants from all states and other countries. We apologize that we're not able to answer all the questions we receive. We pick out major themes from those questions and hope to cover some of those. Dr. Struminger will now go over some logistics. Bruce.
Thank you, Rick, and thanks to Vikram, who will be presenting, and our expert panelists for participating, as well as the 150 plus participants who joined us today. Just a couple of quick housekeeping items. I think most people know, but for those who are new to this session, there's a Q&A function in the Zoom toolbar at the bottom of the Zoom screen. Please put your questions and comments regarding today's presentation there. We'll be monitoring the Q&A area, and we hope to get to as many of the questions you put there as we can, or try to get to them in the future. If you have any technical or logistic issues, please put those questions in the chat function. This session is being recorded, and your attendance is consent to be recorded. Thank you for that. Vikram's presentation that he'll be giving today should be linked to today's email that went out, the announcement. And if it wasn't, it will be on our website within a day or two, along with a link to the recording of today's session. We'll share a link to that website, which has the PowerPoint presentations and links to the recordings of the more than 50 prior sessions that we've had over the last 4, 5, 6 months. Also, CME and continuing professional development credits will be available through the University of New Mexico, where Project ECHO is based. We'll put a link to the survey that will lead to the instant CME about 15 minutes before the end of today's session. That link should also be in today's email announcement that went out from Project ECHO. These, just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Let's keep them apolitical. We really thank you for that. Also, just a note about data use. We really appreciate your sharing your data when you answer the questions, when you reply to the polls, when you register. And we just want to ensure everyone that your data is kept confidential. And when it's shared with Rick and Asper, it's de-identified. So just want everyone to be confident about that. Now I want to pass the microphone to Sharon Van Arsdale at Emory and NETEC. Sharon.
Thank you so much, Bruce. Hello, everybody, and happy Tuesday. My name is Sharon Van Arsdale. I'm the Program Director for Emory's Serious Communicable Diseases Unit. By background, I'm an ED nurse. I'm also the Director of Education and Resources for the National Emerging Special Pathogen Training and Education Center. It's been an honor and a privilege to be able to be on these clinical rounds and represent NETEC, which really allows us to better understand what your needs are, to understand what questions you have, what are we seeing in the chat, so that we can do deep dive webinars and make sure that we're covering the topics that you would like to see. And we had a great webinar on Friday on anticoagulation, and we have several webinars that we're planning now, a couple on remdesivir. We're gonna have something on palliative care, specific related to COVID-19. We're doing one on alternative care sites, and one with behavioral health considerations. So please check us out at netec.org.
Thank you, Sharon. And the Association of American Medical Colleges is also a partner in these clinical rounds. And Rosha McCoy, I know, is here to share an update on the clinical guidance repository. Sharon? Rosha, sorry.
Okay. Yes, I just want to continue to remind folks of this resource that we have available. It's open access. Anyone, you don't need to have a login to get into this. Anyone is able to go into this publicly available site. We continue to update guidance as things change. So we hope it's useful to clinicians, and we would love your feedback. Thank you. I'll put the link in the chat as well.
Great. Thank you, Rosha. And Rick, back to you for the crowdsourcing question for today.
Thanks, Bruce. Today, crowdsourcing question. When you first see this, you'll say, well, I don't have a crystal ball into that. Nobody knows what's going to happen. But I also know that the participants on these rounds are actually taking care of patients and probably know best what the current is and may be able to have some insights into the future better than many. So with that, the question is, what do you predict your healthcare organization's most pressing challenge will be in January 2021? Your healthcare organization's most pressing challenge will be in January 2021. Actually, I'm fascinated to see what those responses will be. I'm going to turn this over to our speaker. Well, actually, before that, I want to introduce our panelist. Laura, if you could please introduce yourself with name, title, affiliation, that would be great. And then I'll turn it over to Vikram.
Thanks, Rick. And hey, everybody. It's nice to be back here. I'm Laura Evans. I'm a pulmonary critical care physician work only in the ICU, and I'm the medical director of critical care at the University of Washington, and had a few-week hiatus from being able to attend these due to being on a really busy clinical service. And so it's great to be back and looking forward to Vikram's presentation.
Laura, thanks for joining us. And as I've said before on many of these rounds, everybody understands being on service. And so no worries on that one. Patients always first. Let me introduce Vikram. Vikram Mukherjee, assistant professor at NYU School of Medicine and director of the Bellevue Medical ICU. Vikram has presented before on the rounds and really has helped us advance our knowledge. And I'm especially grateful for him doing a case presentation for us today. Vikram, really appreciate your stepping up on this one. Thank you.
Thank you, Rick. Hello, everybody. Just going to start sharing my screen. Thank you all for joining today's clinical rounds. We will explore ongoing challenge that happens in the ICUs and on the floors in patients with COVID-19, and that's the presence of the thrombophilic state and the hypercoagulable state. We will start with a brief description of a case. Our gentleman here is a 45-year-old male admitted with COVID-19 ARDS and subsequently intubated for worsening hypoxic respiratory failure. The X-ray on the right is a very common X-ray that you might see in patients with COVID ARDS, where you see these diffuse bilateral patchy infiltrates, meeting Berlin definition for acute respiratory distress syndrome. And obviously you'll see a lot of medical equipment going in as well. Based on most recent data, this patient was started on remdesivir, was started on dexamethasone, and based on institutional protocols was started on therapeutic dose heparin as well. 3 days into his ICU stay, the patient unfortunately had a rapid hemodynamic deterioration with hypertension and tachycardia, and despite having maximal vent support, had a hypoxia to 70% with a good waveform. Of note, his ventilator pressures, his peak and his bladder pressures were unchanged, thus making a mucus plug, barotrauma, and other causes for acute hypoxic failure on the ventilator less likely. A point of care ultrasound was done. Unfortunately, I'm able to show you only one of the views, but here on the left is a view of the IVC. And as you can see here, there is this hyperechoic clot filling up the IVC just at the junction of the cavoatrial, at the cavoatrial junction. On the right side here, you can see on the slide that the entire IVC, at least the hepatic IVC, is full of dense echogenic material, which has found its way from most likely the legs. Of note, this patient was on therapeutic doses of unfractionated heparin anticoagulation during this time of decompensation. Carrying on with this case, the patient went into shock, received therapeutic dose of thrombolytics, but unfortunately had worsening cardiopulmonary hemodynamics and passed away. But I would like to discuss what we saw here and what we've been seeing in, since then is the presence of venous and arterial thromboembolism in patients with COVID-19. I'll go over a brief review of whatever literature there is out there, a pathophysiology of what causes patients to be hypercoagulable, and a brief example of an institutional protocol that might be implementable at the bedside. So what we know so far is that in patients who are admitted with COVID-19 in the hospital have a high incidence of thromboembolism, and this involves not only just DVTs and PEs, but also a larger than expected risk of arterial thrombosis as well. The preliminary data, and forgive me because this is not great data, and we'll come to this in a second, shows a wide range of VTE in patients with across the spectrum in places in Europe where they do, certain institutions do routine Doppler exams on ICU patients on admission. The rates of DVTs can be as high as 70–75%. In other places, it's been a little bit lower, but we do know that patients with COVID-19 now are hypercoagulable, not just on the venous side, but also on the arterial side, with 3 to 5% patients presenting with acute coronary syndromes, with unexpected, unprovoked, otherwise ischemic strokes, and so forth. Trying to understand why is key to understanding how we would treat these patients. This goes back to Virchow's triad, which describes elegantly the combination of endothelial injury, hypercoagulability, and venous stasis. And we will see that in patients with COVID-19, how all these three components can play an important role in making patients more prone to clot formation. For example, endothelial injury. As you can see here on the left, these are based on autopsy findings in patients who have passed away with COVID-19. Here you can see endothelial cell infection of patients, and essentially the thought is that the endothelial lining of our vasculature is extremely rich in ACE receptors, and since COVID-19 has an affinity to ACE receptors, they invade the endothelial lining. And what follows after that is an inflammatory cascade causing neutrophil and lymphocytic migration into the endothelium of the vessels. This on the right here is pulmonary vascular endothelialitis and thrombosis. So not only is there macrothrombi formation and migration into the pulmonary vasculature, but also microthrombi in situ thrombosis, which makes this disease more challenging to treat. There is a huge component of hypercoagulability as well in patients with COVID-19, and this is because of multiple factors. For example, here, there is direct activation by SARS-CoV-2 of your hypercoagulable cascade. There have been cases where increased levels of von Willebrand factor have been noted. There is tissue factor pathway activation. The entire cytokine storm, for whatever that's worth, might make a patient more hypercoagulable. We know from pre-COVID studies that severe hypoxia is a substrate for thrombus formation, which could lead to hypercoagulable state. And there are case reports where there's immune-mediated damage and antiphospholipid antibodies, all adding to the hypercoagulable state. So because there are so many factors causing the patient to be hypercoagulable, we should be aware that DVTs, PEs, and arterial thrombi are exceedingly common in these patients. Lastly, the component of venous stasis comes into play. And here is a brief description of patients who, of the risk factors that contribute to venous thromboembolism. And as you can see here, many of these factors are almost ubiquitous in an ICU patient. For example, age. We know that elderly patients with COVID-19 tend to become more critically ill and die more often. Patients with significant ventilator requirements with severe ARDS are almost always immobilized, which adds to their thrombotic risk. Obesity seems to be a pretty strong risk factor for patients getting critically ill with COVID, so this also plays a role. And as you can see here, all these 6 components for ICU-acquired VTE risk factors are very common in patients with COVID-19 who are admitted in a critical care unit. Patients who are in shock, respiratory failure from ARDS, sedation, which these patients need a fair amount of deep sedation. Almost all patients with ARDS will require mechanical ventilation, central venous catheters, and end-stage renal failure. So we did see here, and we're continuing to see in other parts of the country, that almost 1/3 of your patients in the ICU will develop AKI, and a significant number will require renal replacement therapy. So all of these things add up to why a patient is so hypercoagulable and why our vigilance is absolutely key to be able to recognize thrombus formation. So we know that these patients are hypercoagulable. We know why they may be hypercoagulable. Now, what do we do about it is where we are still missing a lot of evidence. Here, we'll go over the evidence or lack thereof, simply because this is still a fairly new disease. It's barely 8 months new to humanity, and we really do not have yet good prospective randomized controlled trials to guide us better. But unfortunately or fortunately, this is what we have to treat our patients with. And this is a brief review of 3 papers that are out there that can help guide us. So this is a retrospective case study from China, looking at anticoagulation treatment, and showed that it decreased mortality. Again, remember, this is single center retrospective. This is a letter to the Journal of the American College of Cardiology, which showed that treatment dose anticoagulation improved survival. And again, this is single center retrospective, not good evidence yet. And this is another study which has not been peer reviewed yet. It is in Med Treatment IV, which looked at clinical outcomes with use of prophylactic versus therapeutic anticoagulation. And this has swung the pendulum a little bit the other way, which showed that if you anticoagulate people routinely, mortality tends to increase. So what I'm trying to say is that we know that it happens. Unfortunately, we do not really have a good evidence-based protocol or an approach to how we would treat these patients. We have to do and distill the information that we have to the best way possible. So there are, because of the absence of good evidence, you will find that many different institutions have distilled their understanding of the evidence to institutional protocols. And again, when we briefly did a literature, a review of different institutions, there were marked differences between hospitals in the same city and how they approached this question. This is just one possible example, and this is by no means the only way you should approach anticoagulating a patient, but this is one possible approach in where the institution has distilled the information out there to something that's implementable at the bedside. So I'm just going to walk you through it. On the left, all of these, please note that these decisions are made in the absence of objective thrombi. If you find a patient has a PE or a DVT, this dilemma does not appear. You obviously will treat the patient with standard of care heparin or Lovenox. This is in patients who do not have objective clot. So this institution, and I'm going to keep it agnostic because this is not by any means the gold standard, uses D-dimers to risk stratify who to give prophylactic anticoagulation, who to give therapeutic anticoagulation. If your D-dimers are less than 500, as in this case, you might want to start with heparin or enoxaparin. If your D-dimers are more than 10,000 on the higher end, you would want to prefer therapeutic anticoagulation. In the middle here is a place where if your institution is participating in a trial, this one is in something called a PROTECT trial, which looks at prophylactic versus therapeutic anticoagulation. This is a patient you might want to enroll. But other than that, these are patients you might make a risk-benefit decision on whether to offer prophylactic versus therapeutic anticoagulation. The question often comes up, especially in the ICU, should you use Lovenox or heparin or a NOAC or Coumadin? I personally find it comforting that in using heparin, just because it has a short half-life, you can rapidly turn it off and before you do an invasive procedure like a tracheostomy or central line. So in the ICU setting, it might make sense to use heparin, but of course, as you transition to the floors and then home, a longer acting anticoagulant might be more suitable. So future directions, knowing that these patients are prone to a hypercoagulable state, over the next few weeks to months, we hope to see some evidence that assists with patient-centered decisions. The directions that I personally would find useful would, of course, identify patients who should receive full-dose therapeutic anticoagulation, the role of anticoagulation in outpatient COVID, patients who are not admitted to the hospital and have diagnosed COVID, how long we should treat these patients for, and whether there is a role, if any, of antiplatelet therapy. And hopefully in the next few weeks to months, we will have some better data that helps guide what we implement at our bedside. With that, I will stop sharing my screen and happy to answer any questions. Thank you.
Vikram, thanks very much. And by the way, the visuals were awesome. I mean, it was just awesome. It's great. Thanks for the case presentation. And there was one thing before I turn this over to Laura and Sharon for their questions or comments. There's one thing I wasn't, I'm perplexed by. You already had this patient on anticoagulant, on prophylaxis, right? So okay, my guess is, well, I'm sure this was not the first patient that is sort of like you've had this kind of experience with. Were there any like warning shots over the bow that said, or like, okay, this person, even though I've got them on prophylaxis, really fits the profile and I think this could go in this direction? Or is this sort of like in the pattern that you've seen so far with these kinds of patients, is there anything that gives you enough like, this one's gonna be a problem?
Thanks, Rick. So I believe that if the patient is critically ill and just COVID plays just one role in making patients prothrombotic, being in an ICU, immobilized, being older and obese, which makes you come to the ICU, presence of central lines, sedation, and so forth, all are an additive effect to the hypercoagulable state that comes with it. So I feel, personally, I believe that patients in the ICU with COVID have additive risk factors, which makes them more prone to developing a clot.
Yeah, and it sounds like the ones that you had highlighted on that slide that you put in the box in red are the ones that absolutely are fitting that profile. Yeah. Let me turn it over to Laura. Questions, comments on that case or your experience with these patients?
Thanks, Vikram. Well, certainly it was a really dramatic case. I mean, those echo images are impressive and like Rick said, I mean, this is somebody who, correct me if I'm wrong, was on therapeutic anticoagulation already. And I think, you know, one of the things I really struggle with, I think this is a huge, and I appreciate you taking on this topic because I think it's super difficult and there are far more questions than there are answers about anticoagulation in COVID. And is it truly different than critical illness or other respiratory viral infections? Is the incidence truly different? And so I guess I have a couple questions. One is, and not to put you on the spot, but I'm going to put you on the spot a little bit, is how much confidence do you have in these epidemiologic estimates of the incidence of VTE in this population? Because from my reading of it, like, I mean, the estimates of the incidence of VTE here are incredibly broad, right? Anywhere from fairly typical risk to several fold. And anytime I see risk estimates that vary that much, it makes me, I feel like I just don't know where the truth lies within that. And that to me then makes these therapeutic decisions about who to anticoagulate and under what circumstances even more challenging. I think we're in this brave new world territory where you're using things like D-dimer levels in the absence of clinical suspicion of clot to make really big patient care decisions, right? Anticoagulation is not risk-free in a critical care population. So I'm a little bit intrigued if you, one, you could talk about your confidence in the epi estimates, and two, sort of the decision-making process that you guys went through at Bellevue in terms of the development of this institutional protocol using things like D-dimers, and what the considerations went into that. Over.
Thanks, Laura. So I don't know if I have a satisfying answer for you. One is, I agree. I don't think we know how what the true rate of incidence of clot formation in these patients are. I personally believe that it's higher than the typical flu patient or the typical staph pneumonia patient, just because the endothelial lining seems to be heavily populated with the receptors that COVID likes to attack, and the autopsy studies show that there is endotheliitis. So I don't know the true incidence, but I feel, and it's a belief more than a fact or fact-based decision, that they're a bit more hypercoagulable than other similarly sick patients. The D-dimer approach came completely because that was the least worst option we had. Because we were surging, we could not do DVT studies with as much luxury as we would do in a 12-bedded unit, and we couldn't do CT-PE scans with as much luxury as we could in real life. So we fell on D-dimers because of some evidence we had seen that a really high D-dimer level has a much narrower differential and predicts the clot better than other markers. But again, that is really arbitrary, and I honestly don't know if a D-dimer guided therapy will hold up to a good EBM RCT.
Yeah, I think, thanks for that. I think it's really interesting because I think, if I can sort of interpret a little bit, I think if you remember from a couple weeks ago, or maybe even within the last week or so, there was a really nice piece in one of my sources of medical literature, the New York Times. In the New York Times Magazine, there was a really nice long format story about kind of this tension point between clinical researchers and the folks at the bedside, and this sense of clinical urgency, particularly under surge conditions at the bedside, and being faced with, we don't typically see huge volumes of really sick ARDS patients at the same time. Even in centers that have a lot of ARDS, you don't typically have 100 of them. And so you're sort of faced with this phenotypic variation that I think as the treating clinician, you feel like you really, this great sense of urgency to do that. And then the counterbalance is to try to do this in the setting of well-conducted clinical research as well, to ensure that we move forward as a field as much as we can. So I thought that piece did a really nice examination of some of those tension points around the balance between doing high quality clinical research and this pressure to treat the patients in front of you at that very moment as well.
And Laura, if I may just add to that, as intensivists, almost all of us share the same ideology that we have to do something, and that, might be quite counterproductive at times when we are in an area which is completely new and uncharted. So similar to anticoagulation, whether we should be using the TOCI and the stuff like that, sometimes, honestly, as we have discussed in the past, don't just do something, stand there, might be the best approach.
Yeah, reminiscent of many days in the resuscitation room where there's no chart, there's no identification, and the patient's like dying in front of you, and do you stand back or do you intervene, and you have no idea what just none. And so and Laura, okay, a couple questions to you. So number one, the New York Times, that article, I picked up on it too. That was like extraordinarily, it spoke sort of like truth to like, this is actually what's going on right now. That dynamic, like wars at the bedside. It's like, okay, are we actually going to do something, or are we like going to wait for the randomized controlled trial? So is that dialogue happening outside of like, the peer-reviewed New York Times? Is it happening within the societies and critical care that you work in those circles and so forth and so on? Is that kind of dialogue happening beyond, yes, we need more clinical trials, but that tension and that issue, is that being discussed?
Yeah, I think it is. And I think it's being discussed at many different levels and locations, whether it be, sort of large scale organizationally, professional societies. I think it's honestly being discussed at the bedside as well by treating practitioners at the bedside, as it should be from that. And I think, I know you've had some folks on here from the UK, and I think they deserve, the recovery trial investigators deserve an enormous amount of recognition and credit for being able to do a large-scale adaptive RCT in the middle of a surge. And to me, it does sort of highlight that, I really wish as a critical care provider here in the US that we had already had in place a more robust research infrastructure to be able to do large-scale investigation as something's, developing and going on. Because I do think that I feel a great deal of sense of gratitude and appreciation for the sites that were able to participate in research, because I think it's going to help patients down the road. It doesn't help you in the moment with the patients right in front of you, but we know this isn't ending tomorrow. And so having the data from the recovery trial and from other other efforts, even if it's observational data. So, there's a big virus registry here in the US that I think will provide a great deal of information to our approach from that. It'll be, because it's a large scale observational study, it'll be predominantly hypothesis generating, but it'll still be on a scale where we're able to examine some of these associations in a wider manner than just sort of a single center approach to it. So is there a balance? I think of course there is, but I think this conversation is happening at many, many levels. And speaking personally, I would love it if one of the, if you have to, let's say one good thing comes out of this event, I would love it to see if we could, as a country, move forward to helping build that research infrastructure so that we can ensure that we learn as much as we can.
Yeah, and without, just recognizing, as you did the UK study, phenomenal study, and the fact they did that within a national health system as well. Just pointing out that helped facilitate that. And Canadian other health systems across the world have various mechanisms that, quite frankly, we don't have. So, Laura, back to you mentioned or asked Vikram about the D-dimer approach in terms of the protocol they're using. Are you using something similar, or is it dramatically different at Washington?
Yeah, we've taken a different approach, and it is really, I think Vikram touched on this a lot, that the situational piece is really important to this, and that we had an early surge here, but nowhere close to the magnitude that, at least sort of not on a regional basis, nowhere close to the magnitude that's been seen in other areas of the country from that. So we have not changed our standard approach. We're using thromboprophylaxis as we would, favoring pharmacologic prophylaxis, except in patients that have contraindications to do so. And then basically doing additional diagnostic testing for thromboembolic disease based on clinical symptoms or presentation. So we have not changed our anticoagulation approach compared to our normal ICU approach from that. We have had smaller numbers here, I think, than the regions of the country that have undergone significant surges or really big surges from that. So I think it's hard to draw conclusions about that. I think it does illustrate to me, again, the point that we really do need well-designed studies to do that. NIH is sponsoring a large RCT. I think it's going to have an anticipated 2,000 patient enrollment of therapeutic versus prophylactic anticoagulation in hospitalized patients with COVID that I think will be incredibly informative to that. And I can't say, I don't think the approach Vikram's describing is wrong per se at all. I think it's different and it's situationally adapted to a major surge. And here we've had the luxury of being able to, I think, keep our practice a little bit closer to our normal practice.
Rick, you're on mute.
I love it when the speaker tells me I just do. Thank you, Vikram. Yeah, still after 50 rounds. Anyway, Sharon, so how about your in terms of your ICU's approach, and you may not be aware, but is it similar, different, do you know?
And I bet Vikram could probably represent better than I could, but it is my understanding that we've also seen anticoagulation issues. So yeah, so we do have similar standards.
Yeah, thanks. And there's a question for each of, just really rapid response to this question that's in the QA thing. Has there been an increase in DIC noted in COVID patients in the hospital setting? Laura? Yes, no? DIC?
Not that I'm aware of that's been reported. Vikram may have better awareness of that than I do, but not that I'm aware of.
Me neither.
Aaron?
Yeah, I think it's sort of interesting because I think, we kind of, when you get to these really large populations of patients with the quote unquote same disease or same syndrome, which is outside of how we typically see things in the ICU, I think we become really attuned to what maybe phenotypic differences. And I think we've seen this discussion play out, that I know it's come up on this conversation before around, is the ARDS from COVID the same as non-COVID ARDS, or is it in fact a different type of ARDS with relatively preserved lung compliance and more profound deficits in oxygenation while the lungs remain relatively less stiff from that? I've spent a lot of time sort of trying to parse this out in my mind, saying, is this just because I never see 100 ARDS patients at the same time that I'm super attuned to what otherwise you just sort of chalk up of like, oh, that's a little different. And now it becomes in my mind, is this fundamentally different, or is it just that we never see this bell-shaped distribution of this many patients with the same syndrome at the same time? So I'm looking forward to more reports coming out that help us make these distinctions of that. And I think there's another really interesting piece that got published as an editorial from Carolyn Calfee's group in California, basically around this discussion about IL-6 levels in COVID, where people observed, high IL-6 levels in this, and it prompted a lot of, considerations for treating the cytokine storm. And they went back and they looked at non-COVID ARDS and IL-6 levels in non-COVID ARDS, which are actually significantly higher than IL-6 levels in COVID ARDS. So it kind of begs that same question of, is it really different, or are we just looking for some signal there because there's so many patients and we feel this appropriate intense sense of urgency to do something?
Yeah, these have been great insights. I have one more question I want to pose to each of you that came up during one of the initial discussions on the rounds months ago now on the coagulation issues. I don't know, it's probably April. But the question was whether or not patients who were discharged from the emergency department with COVID, I mean, clearly COVID, no question about it, fit the profile, et cetera, the consideration of anticoagulants prophylaxis for those patients. And what are your thoughts on that, like today? Vikram, what do you think?
Thanks, Rick. Again, that's a great question. I don't think we really have the data to guide us. It's going to be a very personalized decision, if you may. But I feel that patients who are going home with diagnosed COVID, they personally do not require anticoagulation. They'll be mobile, they'll be less sick. So a lot of the ICU acquired risk factors don't play a role anymore. And there is a significant side effect to anticoagulating people. So in my mind, the risk benefit of anticoagulating those patients would favor letting them be. But that's just me.
Yeah, no, I get it. I'm looking for, I mean, Vikram, I mentioned in the green room, like with Laura, it's like you have more experience than everybody, along with like a few other people that have more experience than everybody. So, I really value that. Sharon, from an ED nurse perspective, what are you hearing?
Yeah, absolutely. And it's funny because I do remember this conversation because I personally wanted to know, because we were having the conversation at Emory as well. So no, we were not discharging patients home on anticoagulation therapy for the exact reasons that Vikram highlighted, but it also identified the need for proper follow-up. And so really pushing to make sure that patients were getting that follow-up to make sure that, that they weren't having any issues.
Okay, thanks. And Laura?
Same, and we're not doing it here. I'm going to make one more plug and say it's an awesome thing to study.
Yeah, and I tell you, one of the things that it's actually, I mean, it's really great to see like some of these issues, like the Times article. I'm glad you mentioned it, Laura. I really am, because when I read that, it's like, yeah, this is like really important. And yet, while we have increased experience, increased sort of like quote unquote learning with this, we still, and Vikram, you hit the nail on the head. We're only 8 months into this thing. I mean, it's totally new. And so, that's not something that we as clinicians have any familiarity with dealing with I mean, there's no experience with it. And yet some of the same issues, questions around the coagulopathy issue are exactly where we were like months ago now. I mean, we're not there yet. And so, yeah, we've got to get the science taken care of. Anyway, there was one other question that Bruce had pinged me on. Oh, okay. So the testing, when I say testing issue, speaking of the news, but are there challenges with access to testing and rapid return of test results impacting the ICU specifically? Vikram for Bellevue.
For testing, I mean, right now, because we have way lesser patients, we can get DVT studies and CT angios on patients we have a high pretest probability. But these equations change, as you know, Rick, when you have a surge. When you have a surge, almost all testing would have to be redefined and re-explored.
Yeah. Bruce?
Thanks, Rick. Actually, Vikram, what I was getting at was, is the access to COVID-19 testing and the delay in test results that many are experiencing, how is that impacting the ICU, or is it?
That's a great question, Bruce. So right now, we really have really low numbers, and testing is well equipped, so now there is none. In the middle, when we were at the surge, testing honestly didn't have a big role to play because any patient coming in with a SARI-like illness was deemed to be COVID-19, irrespective of a positive or a negative test. I think where testing really would have made a difference was in early March, when the community transmission wasn't as active and we had to make some decisions based on a positive or negative test. But come mid-March, April, May, June, testing surprisingly was inconsequential because any patient with ARDS, SARI, with a negative test was still COVID to us.
Yeah, I think some of the delays are less pronounced in the hospital-based testing than potentially some of the commercial laboratories. That may not be across the board, but particularly in smaller hospitals that may not have in-house testing from it. I think, to me, the biggest implication would be, in areas where I think we are all still extremely cognizant of PPE supplies and trying to be wise stewards of our PPE usage, that we're treating somebody who's being tested as if they have COVID until proven otherwise. And so if there's a long delay there, we are burning through more PPE, certainly while waiting for that test result, which is not great from a resource stewardship perspective, for sure.
Yeah, thanks all. I want to go to the polling as before we actually put that up, because I know many joined after I informed our participants about the schedule, forthcoming schedule. Want to make sure that people are aware that in recognition of what we've talked about a lot on rounds with mental health, fatigue, deaths of clinicians, we want to give everybody a break and have an opportunity to re-energize a bit and take care of their mental health. So next week, we will not be doing any rounds, either the Monday EMS, the Tuesday critical care, or the Thursday emergency department rounds, and we will be restarting, hopefully re-energized, because those 3 hours people did some, I don't know, did somersaults or something really good. We'll restart on August 31st, Monday with EMS rounds. So with that, if Echo could please put up the polling. So for this polling, it was sort of like, okay, we've done over 50 sessions, and we've had quite a journey. All of you have with taking care of patients. Where are we kind of like today with some of the interventions, the treatment? In your experience, I mean, as Laura, Vikram, Sharon, and our sort of collective frustration with not having enough science yet with this, where are we in terms of our experience? So the first question, in your experience, which of the following ventilation support intervention has most improved patient outcomes? Well, wait till you see these results. I'm not. I want to give a few more seconds. It's fascinating, absolutely fascinating. It's about 39, about 40% of you voted. I give it like another 10 more seconds. We'll take a look at these. And yes, I realize it's not the perfectly posed research question, that's for sure. But I'm trying to, Vikram, Lauren, and Sharon, I'm trying to like wade between, well, we don't have science and like, can we at least get some experience shared here? You know? All right, let's stop there. 44% of you voted. Proning, a big one. High flow nasal cannula, big one. Early intubation, not so much. And a lot of don't knows. Thanks very much. So, and I think that reflects a lot of what we've talked about on the rounds in terms of how things have evolved. Next. Now, one switch of a word, okay, which is least improved patient outcomes, okay? So not most, but least improved patient outcomes. About 40% of you voted. We'll wait a few more seconds. I just do want to recognize that and appreciate everybody's responding to the crowdsourced question with a lot of, or those that did respond, a lot of comments were made around two themes, like the impact of flu, the surge, and also staffing. And, well, no, and then a fourth one was the finance piece, or third, finance as well, were themes I saw. All right, let's stop there. 45% of you voted. Least improved, early intubation, 31%. And the don't know answer is a big one as well. Thanks for being like candid about that. All right, next. This one's on drugs therapeutics. And it's similar. We're going to do a most, and then we're going to do a least. So in your experience, which of the following drugs therapeutics has most improved patient outcomes? And while I'm waiting for the responses for that, there was a registration question about hydroxychloroquine. And what I would ask Laura and Vikram and Sharon, if you think I should have added that one on this list, raise your hand. If I should have added hydroxychloroquine on this list. Well, one just raised hand, but shaking of heads, no. Okay, got that answer. Thank you. Appreciate the reaffirmation. All right, let's stop there. 35% of you voted. Dexamethasone, 26%. And it's interesting, you know, we did have our colleagues from UK, and they were just great in terms of presenting the dexamethasone, the trial and so forth, so on. And at that juncture, we had very, very few people that actually had experience with that. Vikram, I think you presented on that one too. And I recall that discussion very, very vivid. Like we had very, very little to none experience, as I recall. All right, let's do the next one. Okay, this is the drug therapeutic that has least improved patient outcomes.
Rick, you might have added hydroxychloroquine to this list instead.
Point well taken. Point well taken. Got 31% have voted. I give it about 5 more seconds. Wow. Okay. Let's see this. Least improved patient outcomes. There's the other 26%. That might have been the hydroxychloroquine. And then convalescent plasma is the next one. All right, the next, let's put the next one up if we could. And for those of you that it's not in your scope of practice, really do appreciate your voting and saying, okay, it's not in our scope of practice, so we get the good sense of how many are out there. Okay, so this one's about convalescent plasma and your experience or your organization's experience with convalescent plasma. And is it helping? Is it not, or you're not sure, or it's improving, it's available but not using it, not available, or not in your scope of practice? And then there are 2 more after this one, and then we'll be done. Actually, I'm gonna after we do this one, it was about 44% of you voted. I want to make sure, I know Sharon and Laura need to leave for their next meetings or whatever, so I want to make sure they have a chance to make any final comments before they leave. All right, let's stop there. 44% of you voted. Looks like the uncertainty at this point seems to be the winner in those that are using it. Okay, all right. Let's stop there. If you can just keep that up for a second. And Laura, any comment before you have to leave? I know you got to leave, so I want to make sure you have a chance to.
I think it's a great discussion, and I'm grateful to Vikram for tackling all the thorny issues here.
Yeah, me too. Me too. Thanks, Laura, for joining. Really appreciate it. Sharon.
Yeah, I echo that. Vikram, fantastic job. And I see all the comments in the chat, and I would love to hear more from both Laura and from Vikram at some point on their thoughts on how this upcoming flu season might impact the clinical care and the outcomes of patients that have co-infection. So at some point, we'd love to have that conversation.
Yeah, we'll work on that one for sure. Yeah, it's in our future. Okay, so let's take that. Thanks, Laura and Sharon, for joining. Really appreciate it. Let's do the next poll question. There's just 2, and these are simple, bimodal kind of things. Our organization is accepting convalescent plasma donations. And while people are responding to that, just for everyone's awareness, I didn't say at the top when we started the polling, all these polling results that you are, your participation, we don't identify individuals and how you responded. We de-identify that piece. It's all the aggregate data. And indeed, we do not just take a look at it, but sometimes we have discussions at HHS with the Healthcare Resilience Work Group on, oh, wow, look at that polling response, and what are we doing about that? So, this is open source information, as it were. Okay, let's stop there. That was a pretty straightforward one. 16% of you said yes, you were accepting donations, 11% no, 13% don't know, and a lot out of scope of practice. Okay, next, please. And the last one. Speaking of the flu. See, I tried to get it in there. try to be proactive. All right, so our organization is doing vaccination planning. Yes, no, don't know. About 50%. I'm going to leave that up for a minute. A lot of people are responding to this. Let's keep going. 52%. Another 5 seconds. All right, let's stop there. Good for the 61%. Yeah, that's good. Some work to do in the other ones, for sure. All right, well, thank you very much. We take that down. Vikram, again, many thanks. Anything you got left to say before we close out?
No, thank you, Rick, and the rest of the panel for having me, and thank you for participants for joining.
Vikram, indeed, thank you for this one. All the others as well, but this one in particular, it was really helpful. And Bruce, thanks team, appreciate it. Anything from you, Bruce, before we close out?
Just great case discussion. Thanks, Vikram. Thanks, Laura. And we'd love to hear from our participants if you'd like to see more cases presented. Ideally, we'd like to have some of you present some of your cases, especially if you have questions about management that you would like discussed.
Yeah, we'd like to move in that direction. And just to add on to Bruce's comment there, you know, case presentations, given our audience, which is extraordinarily broad, across the nation, across the world, but multiple disciplines, I very much view this as thinking about like case presentations from nursing, from EMS clinicians, and from critical care physicians and other disciplines in medicine as well. So that's a sort of a broad ask, and we're going to try to get more specific about that. But really appreciate all the participants participants have been great with participating in the chat, the QA, and to our panelists, Laura, thanks for being on. Vikram, again, thanks very much. And for a reminder, next week, take a break. Next week, take a break. No clinical rounds next week, Monday, Tuesday, or Thursday. Re-energize, do something fun, and we'll see you August 31st, Monday. Take care of yourselves, and we'll see you August 31st. Bye.